Thank you for choosing Lyerly Neurosurgery at Baptist Health. Our goal is to help you lead a fuller life free of symptoms caused by spinal issues. Although no procedure can be guaranteed 100% effective, we have helped countless patients alleviate chronic pain and other effects of spinal issues.
So obviously this is a model of your cervical spine, and just to get everybody oriented, this is looking directly at the front. Obviously you can't feel or see any of that. When you feel your neck, what you're feeling is your trachea. Behind your trachea is your esophagus or your food tube, and then this is the front of the cervical spine. So if we kind of turn it around to the side, you can see this would be the back of your head. When you feel that kind of knot at the base of your neck, what you're feeling is you're feeling the spinous process of the seventh neck bone. So now that you're oriented, basically the spine ends up being fairly simple. It's just repeating units. So you have vertebral body or bone, and then you have disc and bone, and it just repeats itself. The way that we name the different parts of the spine, if you look at this disc right here, it's in between the seventh cervical neck bone, or C7, and then the C6 bone is up here. So the disc in between the C6 and the C7 bones is simply called the C6-7 disc. So 6-7, 5-6, 4-5, and so on. So don't let the two numbers confuse you. When we talk about a C6-7 disc, we're talking about one disc in between two bones. Basically, you have two different conduits or passageways through which neural structures can pass. The big one is the canal, which is the conduit through which the spinal cord runs. And then you also have these side holes called foramina that are the passageways through which the nerves exit. And a number of these nerves will end up becoming the nerves that go to your arms. Each nerve has a specific distribution. And so if you end up, for example, with a problem at C5-6, and you ended up with nerve impingement on the nerve exiting through the side hole at C5-6, that nerve is referred to as the C6 nerve. And each nerve has a fairly specific distribution that it runs. So what you can have is with C6, for example, you can have pain that classically would go over the biceps into this portion of the forearm called the radial forearm, and then into the thumb is kind of a classic C6. And each nerve has a specific distribution just like that. You also have these joints on the back side of the spine called the facet joints. So really, when we're talking about each segment, for example, again, C6-7, we're referring to a complex of three joints. The disc itself, which is the C6-7 disc, and then you have these paired joints called facet joints on the back side. We're going to go over some basic anatomy involving the low back or lumbar spine. Essentially, just to get you oriented, your tailbone would be down here, back of your head would be way up high. When you push on your back and you feel the hard part of your back, what you're feeling are the tips of these spinous processes. Okay, the rest of this is under a bunch of muscle that you cannot feel. So when we look at the spine itself, you just have a bunch of repeating units. So you have bone and then disc and bone and disc alternating. When we talk about, for example, this disc right here, it lies in between the lumbar 5 or L5 bone and the lumbar 4 or L4 bone. So the disc in between L4 and L5 is simply referred to as the L4-5 disc. If you look at the side holes here, at each disc level there are nerves that exit through and become the nerves that can go to your legs. And then if we look around on the back side, what they've used in this model, the electrical cable is not what most people would think it is. It's not your actual spinal cord, it's what we call the thecal sac. And basically what I would think of this as is a long skinny water balloon that runs the length of the canal. It is full of spinal fluid. Your spinal cord does float inside that water balloon, but the spinal cord in adults stops around the L1 level. So when we're talking about any sort of compression or pathology or disc herniations involving the mid or lower lumbar spine, there cannot be any spinal cord compression because there's no spinal cord in the picture at that point. Okay. In terms of disc anatomy, basically each of these discs is made up of an outer fibrous shell called the annulus fibrosus, and then the inner portion of the disc is not what most people would think, and that is that it's often referred to as a liquid or a gel, and when in fact it's not. And not to gross anyone out, but it actually looks very similar to crab meat material. And the point of telling you guys that is so that you understand that if you end up with a problem in which you have some of that material push its way or herniate into the canal and cause pressure on a nerve, it actually has some mass effect, so it can create pressure and irritation of the nerve. If it was a liquid or a gel, it would simply just kind of disseminate across that space and not create any sort of pressure. So the inner portion of that disc, the nucleus pulposus, actually has mass effect and can create pressure on the adjacent neural structures. So when we're looking at these side holes through which the nerves exit, each nerve has a fairly constant distribution, and so if we were to look at this disc, which is the L4-5 disc, again because it lies in between the L4 bone and the L5 bone, the nerve that comes through that side hole at L4-5 is referred to as the L4 nerve. And the L4 nerve, just as an example, would potentially, if irritated, create pain that would involve the hip and buttock. It would travel across the front of the thigh, down the inner portion of the lower leg, and involve the inner part of the ankle. And so the point is that we can correlate spinal compression in many cases based on the distribution of where somebody's pain is, or vice versa. We can see somebody with pain in a very specific distribution, and sometimes even prior to seeing the imaging can make a diagnosis as to where their nerve compression is based on the distribution of their pain they describe. First, I'm going to discuss a very common lumbar pathology known as a disc herniation. Basically, when we're looking at the disc, so again, to go back to our anatomy, if this disc right here is in between the L4 bone and the L5 bone, we're referring to that L4-5 disc. As we discussed, that disc is actually made up of an outer fibrous shell. The inner portion of the disc is not at all liquid or gel. It's an actual solid substance that, not to gross anybody out, but resembles crab meat material. So in patients who develop what we refer to as a disc herniation, we're really talking about a tear in the back of that disc that allows some of that inner portion of the disc material to push its way or herniate into a space where only the nerve should reside. And when it pushes into that space, it can create irritation of that nerve. The type of pain that it can create is what most people would refer to as sciatica. Sometimes people get confused about that. It's not really an irritation of the sciatic nerve, which is a downstream coming together of the nerves that emanate from the spine. It actually is irritation of the nerve root, which is the origin of a specific nerve. And each nerve has a specific distribution. So somebody, for example, who has an L4-5 disc herniation will complain of hip and buttock pain in what we call an L5 distribution. So it would radiate into the hip and buttock, the outer part of the thigh, and can go into the front of the shin and into the top and bottom of the foot. So lumbar disc herniation is a very common thing. In the end, even though yes, it's a disc problem, the underlying root of the problem is really about irritation of that nerve. And so in terms of treating that pathology, there are two major paradigms that one can follow. Either one, we try and treat it non-operatively, and non-operative therapy for a lumbar disc herniation really is about trying to reduce inflammation within that nerve root. So the nerve's being mechanically or physically compressed by this fragment of disc that has no business being there. And so our cornerstone of therapy really is to try and reduce inflammation. And you can do that using oral non-steroidal anti-inflammatories, things like ibuprofen or even prescription strength non-steroidal anti-inflammatories, or you can do a steroid medication. You can't do this for a long period of time, but somebody with a recent or acute disc herniation, we may prescribe them oral prednisone or a Medrol dose pack. Or alternatively, you can even have one of the interventional pain doctors do an injection immediately adjacent to the nerve of steroid. We call that an epidural steroid injection. Everything outside of using the anti-inflammatories to try and treat the inflammation within that nerve root is really symptomatic, at least from a medication standpoint. So using things like muscle relaxers, pain medications, there are some specific nerve pain medications. The two on the market are Lyerly and gabapentin, but all of those are designed to reduce the perception of pain, while we're hoping that the anti-inflammatory effects of those other medications reduce the inflammation and subsequently the pain, and ultimately that the pain resolves. Other adjunctive therapies from a non-operative standpoint could include anything from physical therapy to chiropractic care to acupuncture. And in general, we don't view those things as being dangerous in the setting of a disc herniation. Either they're going to work or they're not. Folks who reach a point where they simply cannot get their pain under control and they reach a point where they feel that they've exhausted their non-operative therapies, they are a potential candidate for what we call a microdiscectomy. And a microdiscectomy is really about going in the least invasive way possible to retrieve the fragment of the disc that does not belong in there, with the explicit purpose of trying to remove the compression from that nerve. And so that surgery is a surgery that we typically do as a 45-minute outpatient surgery. It's done through about a 1/2-inch incision. We do it through a small tube, so instead of cutting the muscle, we actually start with a needle and dock it under x-ray guidance. This is done under general anesthesia, and then we add stacked needles to serially dilate or stretch the muscle so that we're not cutting the muscle. And in the end, effectively, what we are left with is a tube through which we do the operation. We do that with an operating microscope. So it's the least invasive to get from the skin surface down to where the fragment of disc is pushing on the nerve. Once we get in there, what we're doing is pretty straightforward. We're simply trying to retrieve that fragment that's causing nerve compression. Once we've done that, we remove the tube and the surgery's over. What we don't do is go in and remove a bunch of the remaining normal disc material. Okay, there are surgeries in which we do intentionally go in and remove the remaining disc material, but not in a standard microdiscectomy. So I would say with that surgery, in terms of benefits, we are trying to alleviate nerve compression, and so the thing that we're most likely to achieve in someone with a disc herniation is alleviation of nerve pain, which is going to be hip, buttock, and leg pain. Back pain that came on around the time that the hip, buttock, and leg pain did, we can typically resolve that pain as well. However, back pain that's been there for 20, 25 years as sort of a chronic intermittent thing, we don't have that much confidence that we're going to alleviate that portion of the problem. So if we go in and we remove the fragment that is causing irritation of the nerve, the thing that we're most confident if we adequately decompress or take the pressure off that nerve are symptoms that are attributable to that nerve being compressed, which again would be the hip, buttock, and leg. In terms of risk of that surgery, I would say infection rates are around 1% or less. It's quite rare to get an infection from a lumbar microdiscectomy. In terms of blood loss, it's negligible. I personally have never given anybody a blood transfusion for a lumbar microdiscectomy, and we've done this many, many times. In terms of spinal cord injury risk, I would say that in a lumbar microdiscectomy, it's truly 0%. And the reason it's 0% is because the spinal cord in an adult stops around the L1 level, so most of the lumbar disc herniations would occur below L1, and therefore there's no spinal cord in the region that we're doing surgery, and I would say that it's virtually impossible to create a spinal cord injury in that scenario. The risk of nerve injury can't be 0%, but it's way under 1%, so it's quite low. And there is this, what we call the thecal sac. It's basically kind of a long, skinny water balloon. As I referenced in the anatomy portion of the talks, this is not your spinal cord. It's this water balloon that the spinal cord floats within and the nerves. Here we just have nerves. It's a very thin-walled structure. It is not impossible to get a little tear or a pinhole in that water balloon that would cause a CSF leak. Typically, CSF leaks are fairly inconsequential. They can create a headache for a couple of days, and most are fairly self-limited. But occasionally, if you have a significant leak, it could require an additional surgery to go in and repair that if it was not repaired at the time. It's still pretty unusual. I would say the risk of a CSF leak is around 2 to 3%. The biggest risk that folks face when they have a lumbar microdiscectomy for treatment of their hip, buttock, and leg pain is really the risk that they would have a recurrence at some point. So it's not a risk within the surgery, it's a risk that we go in, we take the pressure off the nerve, hopefully alleviated all of the hip, buttock, and leg symptoms, and the patient's potentially back to normal, and then at some point it could be 2 days, 2 weeks, 2 months, 5 years, but in their lifetime the risk of having another fragment push its way back out of the same disc and create the same problem all over again is somewhere in the 5 to 8% range. We like to think of it as a 92 to 95% chance that patients won't have that sort of thing happen again, but that's at the top of the list for things that could potentially obscure long-term benefits from doing this surgery. As far as recovery is concerned from a microdiscectomy, in my practice I would say that 99% plus of the patients who have this surgery would be discharged the same day because their pain is controlled, they're up and mobile, and they want to go home. Anyone who asked us to stay in the hospital, we'd be happy to keep them, but almost everybody wants to go home the same day. We don't have any significant restrictions as far as being up and about, sitting in a chair, walking around leisurely, even going to a restaurant with their family if they're feeling like it after surgery, so there's no prescribed bed rest after the procedure. We do, however, say go easy on the lifting, bending, yard work, playing tennis, things that would involve a lot of stress or torsion or ballistic movements, jogging, for example. The point of doing that is to try and theoretically reduce the risk of reherniation, even though we don't have any science that says that we're actually doing that. And we say kind of rein those activities in for about a month after the procedure. So again, there's no prescribed bed rest. You can get up and do leisurely things right out of the gate without significant limits, depending on how the patient feels. However, we don't want folks doing a lot of strenuous back type exercises or activities for about a month after the procedure. Return to work is not uncommonly for folks who don't have manual labor duties in their job. So the guy who is, say, an accountant, he would probably be back to work in less than a week after this type of procedure. But then again, we would restrict his usage of the gym or yard work for about a month after the procedure.
Our goal is to help you live a pain-free and fuller life. If you have any questions, our staff is here for you. We will be with you every step of the way. Thank you for allowing us to care for you.